Tonight, we have two guests from the Mayo Clinic to discuss pancreatic cancer and internal medicine issues. The Mayo Clinic, a history of excellence. Tonight on Call with the Prairie Doc.
Starting this season, we are offering a Facebook Live option for our viewers to still be able to watch the show during the regular broadcast times on Thursday nights and ask questions. All you need is either your laptop, tablet, or a mobile device, such as your smartphone, to view the show. Here's how to do that. First, log into your Facebook account. If you don't have a Facebook account, go to facebook.com and complete the information to create an account. In the search bar, type in Prairie Doc. Make sure to click like on our Facebook page so you can get updates and notified when we are going live. Each Thursday on the Prairie Doc's page, you will be able to see a live broadcast of the newest episode. You can also ask Dr. Holm questions via Facebook Live. All you have to do is ask your question in the comment bar and await a response. If you miss a show live on Facebook, it will be available later both on the Prairie Doc Facebook site or at prairiedoc.org.
Good evening and welcome to On Call with the Prairie Doc. About a year ago, I was diagnosed with pancreatic cancer. Since that time, I've seen many doctors and have been through a variety of treatments. At some point, it was recommended that I go to the Mayo Clinic at Rochester, Minnesota. As it turns out, that was the right decision. I'm still here with you. First, let's take a look at this week's Prairie Doc quiz question. A primary care doctor refers to a subspecialist often to help define the diagnosis so as to better treat a condition. A Mayo Clinic study showed the percentage of the time the final diagnosis was entirely different from that referral diagnosis was A, 12%, B, 21%, C, 99%. Diagnosis was different than the reason it was referred. 12%, 29, 99. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your medical questions about the Mayo Clinic, internal medicine, or pancreatic cancer as they are called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on the screen. This is your show. Your questions matter. We want to answer them. Joining us tonight is Dr. Robert Lohr, an internist and a consultant at the Mayo, and Dr. Mark Truty, abdominal surgeon, pancreatic cancer researcher, and the guy who cut out my pancreatic cancer on May 10th. We are so pleased to have you.
Glad to be here.
Thank you. Bob, you and I have known each other for 4, 5, 6 years, something like that.
Longer than that.
Through internal medicine organization, the American College of Physicians. Mm-hmm. Are you still on their major board?
Yeah, I'm on the Board of Regents, and I'm treasurer of the college.
So, and you will be the president probably.
No, I don't think so. Not in the cards.
But that's a very important position, and as a general internist, you're at the Mayo Clinic. Now, a lot of things have happened in going into subspecialty areas, but you're a generalist.
Right.
So how does that work at the Mayo Clinic with all these subspecialists?
Yeah. Actually, the General Internal Medicine Division is the largest division within the Department of Medicine. There's over 100 physicians. And then there's another primary care group of another 50 or 60, and hospital medicine is 50 or 60. So there's a couple of hundred general internists, and you're right, people ask, what are they doing there? You've got all the cardiologists and the gastroenterologists. Many of the patients, I would say the majority of the patients that we see, whether they're local, regional, or coming from abroad, have more than one thing wrong with them. And they really want a very comprehensive evaluation. So they start in general internal medicine, and then we help send them off to the cardiologist, to the surgeon, whatever they need, but try to help coordinate the care and keep things together. And when they're done, have a fairly tight package of recommendations for them and for their physicians at home.
Right. And you're originally from where, Bob? I mean, where's your home?
Columbus, Nebraska.
Grew up in Nebraska.
Grew up in Nebraska.
And then you went
I'm
to...
a Cornhusker.
You're a Cornhusker.
That's right.
I kind of thought I knew that. And then you went to med school?
In Chicago at Northwestern. And I trained at Hennepin County in Minneapolis.
And then you practiced in Minneapolis for a period of time?
For about 10 years, and then I've been at Mayo for 24 now.
Okay. Well, welcome.
Thank you. Pleasure to be here.
And Dr. Truty, you're a general surgeon or an abdominal cancer surgeon. Explain your training for me, Mark.
So training after medical school, I did my general surgical training up in Rochester. After that, I went out, did some more subspecialty training in surgical oncology, specifically liver, pancreas, and GI cancers. And then now I've been back at Rochester now for going on 6 years.
So 6 years now. Mm-hmm. And there are how many surgeons that do, let's see now, I had the Whipple procedure.
Yep.
And there are how many surgeons at the Mayo that do the Whipple?
In Mayo Rochester, there's 6 of us.
Right. Could you explain, I've been told that the Whipple procedure is one of the more aggressive surgeries that there is. In fact, I remember in medical school back many years ago that they said that 50% would not survive that surgery. That's changed now.
That's changed dramatically. It is a very complex operation. It involves the pancreas, which is located deep within the abdomen. It's surrounded by a lot of critical structures, particularly arteries and veins. It's basically the intersection of your GI tract, your liver, your bile duct, and your intestines. So operating on that area is technically complex. The outcomes have significantly improved over the last 3 decades. We've become very good at what we do. The key thing is you want a surgeon that does this often, does it in a high volume, and also being done at a center that does it as a high volume as well, because complications still can occur, and you have to manage patients through those complications.
Right. But you do other cancer surgery on the bile duct and the liver.
Yeah, we do liver operations, we do stomach operations, sarcoma operations. That's the bulk of our work.
Right. So, and you do research. Mm-hmm. Explain some of that research.
Yeah, so some of the research that we do, different types of research. It could be basic science at the bench. It could be clinical research, specifically with patients and trials. And then one of the things I do run a lab. It's a translational lab where we take patients' cancers that we take out at surgery. We grow them in special breeds of mice where we could basically grow that patient's tumor, and we could test different drugs and look for different tumor markers, et cetera, to help either diagnose, treat patients effectively on a more individualized basis.
Right. And my cancer was an acinar cancer versus an adenocarcinoma. Could you explain a little bit of that in a way that people would...
You bet.
Because I think that's interesting.
Yeah. There's different types of tumors that could grow in the pancreas. What you often hear is pancreas cancer. That's sort of a general term for what we call histologically under the microscope. It's an adenocarcinoma. That's about 90% of all pancreas cancers are of that subtype. Your particular tumor was actually a very rare subtype. It's actually a mixed tumor between a neuroendocrine carcinoma and an acinar cell carcinoma. So a bit unusual, but still, pancreas cancer.
I've been called unusual my whole life.
and with good reason.
So we have some questions. We might as well just kind of dive into some of these. A man from Sioux Falls wonders what is the newest procedure for treating pancreatic ductal carcinoma? Okay, newest procedure.
So in terms of procedures, technically procedures, we're doing a lot more minimally invasive operations. So traditionally, just like removing a gallbladder used to be a big incision, now we can do them through smaller incisions. The same things
robotic.
happen. Yeah, robotic, you bet. So anything done to help people recover from their operation faster. The key thing is you still have to be able to do the appropriate cancer operation. That's first and foremost. But if you get them heal faster, get out of the hospital sooner, and recover faster, that's all obviously best for the patient.
But I didn't get the robotic procedure. I had these big, huge... So why did I not have the robotic?
So some of it, that's still relatively new. So the Whipple, the laparoscopic Whipple, we do have a surgeon that's probably leading the world doing that. There are still some limitations. Your particular cancer that we operated on was involving one of the significant artery. So we had initially planned on doing an arterial resection, which is a procedure that's not performed very often. Anywhere in the United States, we happen to perform more of these unblock arterial resections more than any other center. But the risks of those operations are significantly higher.
So Bob, in taking care of somebody following pancreatic surgery or abdominal surgery, there's a lot of medical complications. Could you describe that?
Yeah, often there are, because patients are old and frail, or they can be young and frail, but they have other things going on. One of the most common problems that we have, particularly in the frail elderly, is they get a lot of delirium postoperatively. You have to use some opioids, some narcotics the first few days, but they're not that well tolerated, and we get a lot of confusion. We have to deal with that. There's a lot of kidney problems after a long surgery. Blood pressure tends to drop in the operating room. The kidneys don't get quite the blood supply that they would, and so there's some kidney issues sometimes afterwards. And then if someone comes in with kind of a weak heart, that can be aggravated too. So there's a lot of things that go on, and we try and work with our surgical colleagues to, get the patients through these. It's important that we understand what the surgery entails and what the limitations that what we might recommend are in terms of someone being postoperatively. For example, you don't want to completely anticoagulate or thin someone's blood right away after an operation because they've just had the surgery, they can bleed. Mm-hmm. And yet there are times when we almost have to do that. They have an artificial heart valve, things like that. So it gets very complicated. One thing I wanted to go back to is what Mark said a few minutes ago, and that is when you're having a procedure of any kind, that it's really important to make sure that you're at some place where it's done a lot. And patients ask me in the office, is the surgeon good? And they've done this before. They should ask the surgeon that. Mm-hmm. They don't always. And I said, they are. The surgeon's very skilled, and they do this all the time. And that's really what you want. You want to go to a place where whatever the procedure is, it's the usual Monday morning. This is nothing special. We do them several times a week, not several times a year. And we have all the backup, the personnel, the support to help if something does go awry or if we need to go a little different direction. But that's really, really important.
Yeah, and that's been demonstrated with a significant amount of evidence. Patients do better when they're operated on by surgeons who do that at a high volume, as well as at a hospital that also treats those conditions and those procedures at a high volume. One aspect is the operation. Are they getting the appropriate cancer operation? Is it technically done as best as possible? And then how are they taken care of afterwards? Can they recognize a problem? Can they act on it, and do they have all the supportive staff to get those patients through it?
Right.
It's a twofold issue.
Right, exactly.
Right. One other, what is the hereditary factor of pancreatic cancer? My uncle died at 58, and my mom and her siblings are concerned. Okay, so what is a hereditary factor with pancreatic cancer or any cancer?
So in general, in the general population, there's about a 1 to 2% risk of a patient at any point in life being diagnosed with pancreas cancer.
So anybody off the street?
Anybody
1
off
to
the
2% cancer?
You bet, to get this disease. So it's not a very high incident cancer. However, it is a very high mortality cancer in terms of number of cancer deaths. Most pancreas cancers are sporadic, meaning they just happen. Like any cancer, cancer is basically all our cells have brakes and they have gas pedals, what we call tumor suppressors and oncogenes. What happens when a cancer develops is the gene that normally keeps things from growing gets turned off, and genes that keep things that allow things to grow gets turned on, and that defines the cancer,
and it goes
regardless of subtype. Most pancreas cancers are sporadic. There's a very small percentage of what we call hereditary. We can see those in patients with BRCA mutations.
Yeah, breast cancer.
You bet, breast and ovarian cancer. There's a variety of Lynch syndrome. There's some patients with familial pancreas and melanoma, but these are in the minority. So typically when we worry about a familial component, we're looking at 2 direct family members with pancreas cancer. That's when the risk rises and we do some more screening in those particular families.
But in this case, probably there's not a lot of increased risk with one relative.
Not a lot of increased risk, unless that patient was very young and had no other risk factors.
And if there's more, what about just cancer in general? I do think that that's something that I see when I'm caring for an elderly person or a middle-aged person, and they've got a lot of family history of cancer. It's not the BRCA breast cancer thing, it's just a lot of cancer. I'll often think that there is a higher risk of cancer in that, even though it's...
It depends on the type of cancer. Breast cancer, yes, there are certainly hereditary factors. Colon cancer, there are hereditary factors, particularly if the relatives are first-degree relatives, parents, siblings, not Aunt Tilly from 10 years ago or 50 years ago, but first-degree relatives. And then if there is Lynch syndrome, which is a hereditary polyposis problem. So those are the main ones in terms of family history. The rest of it is more sporadic, frankly.
Okay. Knowledge is power when you're dealing with life-threatening disease. Support comes from the medical staff, doctors, and of course your friends and family.
I woke up one morning. At the end of our bed, we have a very lighted bedroom. My wife said, "What is wrong with you?" And I said, "What do you mean?" And I had turned completely yellow. So of course, we went to the Fort Meade Hospital in Sturgis. At first there was hepatitis, and then found out later in a couple of days that I had pancreatic cancer. Our doctor there had read an article about a doctor in Mayo Clinic in Rochester that was helping patients with pancreatic cancer. Put me through the program of chemo, radiation, and then finally surgery in September of 2014. And it was a Whipple surgery, you know, basically open you up, go inside and until they can find the tumor. And in my case, I did all the procedures first. Most cases are done where they do the Whipple first and then they do the chemo and radiation afterwards. But in doing so, they had to replace an artery supplying blood to my liver because it had been damaged and because of the pancreas and that, and they had to replace it with a hog artery. I got out of surgery, everything was fine. So I was in the hospital for quite a lengthy time, almost 3 weeks. And after that, more radiation, more chemo, and then I got to go back, and things steadily got improving. They did have to put a stent in. I am still cancer-free. I go back every 4 months. It was 3 in the beginning, now it's every 4. But whatever you do, don't give up, and have somebody that, I'm so glad, I'm so fortunate for my wife. The support is what you need. I thank Rochester, Minnesota, and Dr. Truty over there, because he's the man that saved my life.
Hi, this is your show. Your questions are key to our show discussion. Call in your questions about the Mayo Clinic, about internal medicine issues, any issues, and abdominal surgery and pancreatic cancer to 1-888-376-6225, or send us an email to ask@prairiedoc.org. We appreciate that. So that was an interesting gentleman, and of course, Mark, you know him.
Yes.
So he had metastatic cancer to his liver, and he spoke to it. And so it's amazing to me that a man who would, at that point, would have stage 4 cancer, and then he's now 3.5 years out or so. We appreciate his being on the television and showing us and talking to us about his cancer. Do you see that kind of response in other people?
We are seeing more and more of those responses. This is, again, it's really changed not just the technical aspects. We've become really good surgeons over the last 3 decades. We could do very complex cases. But the problem with pancreas cancer, a knife can't control biology. And that's where we really need to depend on our medical oncologists to come up with something more effective to treat the whole body. I always talk to my patients, it's like a dandelion. If you mow over a dandelion, what do? You get 100 more dandelions.
Yeah.
You need good weed killer.
Yeah.
Okay, and we have much better weed killer, so to speak, for pancreas cancer these days. That's literally only the last 5 years. We have 2 major regimens. They're about 2 to 3-fold more effective than traditional agents in the metastatic setting, and we're finding even significant more response in patients who have relatively localized disease. So we're seeing improved survival in patients. We're seeing we're able to apply the modality of surgery, which is the only curative form, to a much larger fraction of patients. And we're doing operations we never even thought would be possible.
So I had 3 chemo agents combined. One was a platinum, a cisplatin. Another is
FOLFIRINOX is the
It's FOLFIRINOX is a combination of 3 agents, and I had 3 doses when I saw you, and you said not enough. You want to go to 6 because your research showed less than 4, 2.5 years survival, more than 4, 5-year survival, something like that. Am I correct in quoting you?
Yep.
And so it's the chemo that makes the difference. But people hate, I mean, they don't want to hear that. I mean, people have a reaction to chemo.
Fun.
What is your...
You know that. It's not fun.
It is not fun. What is your comment about chemotherapy? It's an internal medicine.
Yeah, no, well, it clearly plays a role, you know, that we call this adjuvant chemotherapy. It's,
you do the surgery and then you add the chemo.
Well, or you do the chemo, then you add the surgery, and then you may do more afterwards, and then you may have some radiation thrown in.
Right.
But as Mark said, the outcomes are much, much better than just the surgery alone. And the reason is the surgeon, as skilled as they are, you can't see cancer cells. And they can spread via the lymph glands, they can spread via the bloodstream, direct extension, there's numerous ways. And you remove what you can see, but you can't see everything. And the chemotherapy addresses the rest of the body. Unfortunately, much of it, not so much the immunotherapy, but the traditional chemotherapy has lots of side effects, and that's why people, you know, kind of put up their hands, and it isn't fun. But I think the medical oncologists are much, much more skilled now than they used to be in alleviating or mitigating those complications.
And the key thing is, as you said, the traditional method was you'd operate and then you'd apply chemotherapy. The few things that we have really high-level data for is getting chemotherapy after surgery does prolong survival. But in general, those patients as a whole haven't done very well for 3 decades. So we're turning things and now giving them all their chemotherapy up front. What we found is those patients that had surgery and then tried to get chemotherapy, less than half even started it. Mm-hmm. And of those that did, many didn't even finish it because it's very difficult to get chemotherapy after recovering from a big operation.
Right.
Yeah.
We're finding that we have better chemotherapy. It's a lot easier to tolerate prior to an operation. And then if there is an issue with recovery after surgery, we're not all wringing our hands worrying about the cancer because it's been as treated as possible. What we call total neoadjuvant therapy.
Neoadjuvant.
Yeah, you bet.
So you said adjuvant, and neo is before.
Neo is before.
Right, and then you also had me get radiation.
You bet.
So the science for that is still pretty weak, though, right? I mean, it's not there yet, right? Or is it?
No, the science is there. It's about changing the mindset and the philosophy. Each
timing.
of these components have a specific purpose. The purpose of chemotherapy is to treat the whole body. It's not the tumor that everyone talks about that takes people's lives. It's the seeds. That's the purpose of the chemotherapy. If we have a response to the main tumor, that's a surrogate that we're also hopefully killing all those seeds.
Yeah.
Once we've hopefully sterilized all these, micrometastasis, which are the spread of the cancer, which we know most people probably have at diagnosis, we then start focusing on the local area. Radiation is like surgery, it's local. I use radiation specifically to allow me to have a negative margin. What's a negative margin? As a surgeon, I have to remove the tumor without leaving cancer cells behind. If I do an operation, I leave cancer behind, there's no benefit to that operation. That's been proven. Mm-hmm. Radiation allows me to have a much higher probability to offer a best cancer operation for that patient.
All right. So I think the message that we're hearing is that the bad rep that people have with chemo and with radiation is inappropriate because there's our chance.
Yeah.
Mm-hmm.
That's the killer of the
seeds.
seeds.
It's the multimodality approach, though, that I think has really made the difference.
Yeah. Wow.
And the key thing, it's a lot easier for a patient to tolerate some of the side effects of chemotherapy if we could demonstrate that it's actually being effective.
Yeah.
Whether it's a tumor marker going down, whether it's a tumor shrinking, whether it's a PET scan changing. Once a patient sees that, hey, what I'm taking is working, it's a lot easier pill to swallow, no pun intended.
So I have to say that I've gone through the chemo, and it hits you like a ton of bricks, and then, but you're getting over it, you're getting better, you're feeling better, and then they hit you again, and then you get over it, and so I did that 6 times. I'm glad I did it. Look at this. We are out now. October is a year, so October, November, December. I mean, we're out 14 months now, and there is, like you say, a much smaller chance of surgery being successful. What is it? Tell me the percentages again. What percentage of people can go to surgery for pancreatic cancer?
So traditionally, we looked at people and whether they're resectable. Okay, there's a problem. There's a big difference between what resectability is and what removability. Removability is I could separate that patient from that tumor. but there's constraints. Is that actually going to be a benefit to them? What's the consequences of that? Is it going to be a good operation? So resectability means, can I take that patient to the operating room and actually look them in the eye and say, this is going to accomplish our goals? What are our goals? The goals are not an operation. The goal is to extend that patient's life and either maintain or improve their quality of life. That's the goal for anyone with cancer, and we're trying to do that with surgery. The traditional method, we've just focused on a very small group of patients whose tumors were just localized in the pancreas with no vessel involvement. We took them to the operating room. Some of them maybe got chemotherapy, and what are the results of that? They're pretty poor. For 3 decades, it haven't changed. We're changing things now. We're giving them all their therapy up front prior to surgery. We're applying this to a larger fraction of patients. We're doing bigger operations that people thought were never even technically possible. If we get them through that, those patients in general do much better than average, period.
Right. Wow. And what were you going to say?
Well, I was going to say, in terms of managing the chemotherapy and the side effects, it does knock the wind out of your sails. You know that personally. But it's also temporary. And you're going to get better. The appetite will come back. The nausea will be better. You may have to have another round, but it is, it's sort of like you break a bone, it'll heal, I'll be okay. This also gets better, and I think people have to keep reminding themselves of that and be reminded of it.
Be reassured, yeah.
And that's the key thing. Unfortunately, as surgeons, we always kind of focused on, can I get the patient out of the hospital in 30 days without a major problem?
Yeah.
We've gotten really pretty good at that. We're doing these bigger, larger operations, and patients are getting a lot of therapy. Again, what's the goal? I don't care about my 30, 90-day survival. I care about what's the 5-year survival for these patients.
I'm hoping that, oh gosh, Mark, I got you.
And so the key thing is some patients may take a larger upfront risk to get that long-term goal. And these are conversations that we have with them. So.
Okay, we'll need to have some help with the water that I spilled on Mark.
No worries.
Sorry. And I wanted to talk about the symptoms that a person with pancreatic cancer might have. Now we're talking about treatment. It'd be nice to be able to catch it early.
Yeah.
How can we do that? What symptoms does a person have that might be a clue?
And Mark can pipe up too. Sometimes there really aren't very many specific types of symptoms. It's not uncommon, and I think you experienced this. You had some belly pain, but all of a sudden you're jaundiced. Your eyes are yellow and your skin's turning yellow, and that's because the tumor is blocking the outflow of bile, into the GI tract. So that happens. Abdominal pain, loss of appetite, weight loss, sometimes nausea and vomiting, sometimes not at all. And unfortunately, more often than not, the patient comes in when symptoms are kind of advanced, and the tumor is unfortunately kind of advanced. Either there's a fair amount of local spread, or it's, as the gentleman in the tape, it's in their liver or someplace else. And that goes back to, well, why can't we find some sort of a screen or a screening test for pancreatic cancer?
What kind of screening test can I do?
Well, you have to ask, you have to back up and say, well, what is a valid screening test? What does that mean? And it means that a patient of average risk for whatever the condition is, and no symptoms, that we can do a blood test or an x-ray or something, make a diagnosis, and with that information, cure the cancer.
Right.
Pancreatic cancer currently does not have that. And there are very, cervical cancer does with pap smears and viral testing. Breast cancer does with mammograms. Colon cancer does with a variety of things, colonoscopies and fecal testing, DNA testing, and so forth. Prostate is a little more controversial with PSAs.
Yes, it is.
But nevertheless, that's about it in the current state of the art.
So we don't have a screening test.
We do not.
CAT scan, screening people with CAT scan doesn't work, does it?
It doesn't work. And what we see in pancreas cancer is not, when we look back and be the patients who've had scans for other reasons. It's not like you could see a small tumor that's just slowly enlarging. Pancreas cancer, it's more stochastic. It's nothing there, and then boom.
Stochastic.
Then there's something there. It has these kind of steps.
Right.
And unfortunately, the metastatic step, meaning when it has cells capable of leaving, unfortunately, that happens many years even before even develop symptoms. That's what makes it so difficult.
It's a tough issue.
It is.
Yeah.
Quick questions, quick answers. Man from Brookings, stomach cancer diagnosed a year ago, now has cold and numb toes and swelling on the bottom of his feet. What can he do to get rid of this? peripheral neuropathy from
the chemotherapy. Yeah.
Yeah.
How
That's
well I-
usually the oxaliplatin that typically leads to that. It tends to be cumulative over time. The more chemotherapy of that particular type they get, it can get severe. Some patients have none of those symptoms. Some patients it's mild. Some patients they have to stop therapy. There's been no real hard data to suggest what could make it go away. There's been some studies looking at zinc and magnesium supplementation to help with the nerves, but that has not really proven, at least in general.
I mean, you can try the gabapentins and that sort of
To
thing.
help them live with it, but that's
right, but it's
symptom control
It's
only.
symptom control. That's exactly right.
My point is, and I'll give you this answer, is that when I have the ringing in the ears and the numbness of my feet, I go, and I'm not dead from cancer. Thank you, and I'll live with it.
Being upright is better.
Upright is a good thing. The amount of fight in a patient can have an effect on how well they deal with the weight of treatment. It can give them a feeling of some control over the disease and to focus on the long-term results.
But you bring up
And they're going to go to...
In 2014, I went in for my annual physical, and I went in the doctor's office, and the doctor looked at me, and he's one of the doctors that happens to know me better than I know myself. He said, "Moisten, you're too thin. We need to find out why." And I go, I'm busy. I'm a caregiver. I take care of my wife. I'm taking care of the farm. You know, I do the laundry. I do the dishes. You know, I do all of that stuff. And I go to the gym 4 days a week, and I'm not a disgusting fat body like I used to be. And he said, "No, we're going to do a CAT scan." He said, "You've lost 11 pounds in a year." And so I said, "Okay, you're not going to find anything because I'm not sick." I said, "I feel fine." 23 hours later, he put his arm around me and said, "You need to put your wife in a nursing home. You've got pancreatic cancer." First thing that happened, I was scared, because you always hear that pancreatic cancer is you're a goner in 3 months. And so, I mean, it compelled my wife and I both to get our affairs in order, our wills and our estate and everything in order. And then after that I got mad. I was pretty mad, and I started going back to the gym. And I remember thinking, I got a punching bag there. And I remembered getting the boxing gloves from the front desk and putting those boxing gloves and going up and punching that bag every day 100 times, as hard as I could, as fast as I could go. And just imagining in my mind that was one big tumor, and I wasn't going to let this cancer come back. I went to Sioux Falls on the 27th of June, 2014. They did a endoscopic exam and needle biopsy of my pancreas and found a 4.3 centimeter tumor on the tail of my pancreas, which is, I guess it's good news on the tail of your pancreas, better news. In January of 2015, I started on chemoradiation. I had 5 FU and radiation every day, 5 days a week. That was sort of uncomfortable, but the way I always looked at this stuff, none of this was more uncomfortable than basic training in the Army. I mean, it was because I always knew that there was going to be an end to it, and just like I knew there was going to be an end to basic training, so I just kind of toughed it out. And so, so far, as of 2017, I'm still without a recurrence. I don't use the words cancer-free. I don't like cancer-free very well. I don't use that. I tell people that I don't have cancer now. I know, and this is the message that we're doing here today, and the message that I tell people all the time, is build a relationship with your doctor, get to know your doctor, and have your doctor get to know you.
Now that was John Moisten, who organized the Capital special event for pancreatic cancer and turned the Capitol purple. A wonderful man, a tremendous friend, and I just thank him for bringing this together and to being my support person through my hard times. Thank you, John, and thanks for saying your story about being in the Army. Knowing that there's an end to it is an important thing. And I also mentioned that, you know, what I usually do for people who save my life is to throw water on them. Sorry about that. Well, we've got great questions coming. A man from Brookings had stomach cancer diagnosed a year ago. Now has we asked that one already. The 73-year-old caller had a heart failure diagnosis from history of high blood pressure, but didn't have any testing. Should there be more tests? So he had heart failure following long-term blood pressure problems.
Yes.
Yes, he should have more testing.
I think there are several types of heart failure, and the way you determine that is to do an echocardiogram. It shows how the left side of the heart is pumping, or if this is an issue more with the right side, or what we call diastolic heart failure. So yes, an echocardiogram would be important, and that can guide therapy.
So, and I think that's interesting that high blood pressure over a long period of time brings on heart failure. Valvular heart disease, valve disease will bring on heart failure.
Rhythms can.
Rhythm abnormalities.
This is most likely left-sided heart failure because the heart's pumping against the higher pressure, and that's where you're going to see the problem. But the echo would sort that out.
And it's very important to get that echocardiogram.
Yes.
Yep. Caller is taking Coumadin for atrial fib. How can you get numbers from 1.5 to 2 without increasing the dose? He has a hematoma from a fall. He doesn't want to have higher dose because he already has a hematoma.
Well, warfarin, Coumadin, is a vitamin K antagonist, so anything that you eat has some vitamin K in it. Some things have more, but what you're eating affects it. If you're drinking much alcohol, it can affect it. Many medications, particularly antibiotics, can affect it. So it does make it very, very hard to manage, and that's the advantage of the newer agents that work a different way, and they are not affected by diet. They have some downsides too, but by and large they're simpler to use, and the most recent literature shows that they're actually quite safe, and probably safer than warfarin in terms of bleeding complications.
Tiny little differences though, and my comment is that the bleeding risk of those drugs, warfarin and the others, it brings us to be the highest risk drugs that we prescribe.
Well,
and there's only one drug that we can monitor and know how effective it is, whether the compliance is good, and where we're at with it. And so my sense is warfarin is the better option.
Well, it depends on the patient.
It's reversible too.
And it's reversible.
It is
From a surgical point of view, as you said, those are very dangerous drugs, particularly in surgical patients.
No, that's absolutely correct. The newer agents are somewhat reversible, and there are some new drugs coming out to reverse them. Dabigatran does have a reversing antibody. But you're correct. It does depend on the patient.
It does.
They are more convenient. They're easier to use. They are more problematic if the patient breaks their hip and we have to go to the operating room right away. That is a big issue. But there are advantages, and if there is a significant bleeding risk, whether it be a hemorrhage in the head or GI bleeding, they're safer than warfarin. And that's because of exactly what your caller said. The thing goes up and down willy-nilly, and you can't control it.
In atrial fib, you look at it, the warfarin or any of the anticoagulants reduces the stroke risk from, it depends upon the complication of the person, but, anywhere from 8% down to about 2 or 4%. But it's not eliminated.
It's not zero.
And this person has a hematoma and they're following. My concern would be any of them might be more dangerous than to
True. You could then back up and say, what is this patient's stroke risk in terms of their atrial fibrillation? Because there are ways to figure that out, and if it's not that high, you could stop the warfarin temporarily and then go back on.
Yeah, that's the issue. As soon as you have a bleeding complication, you have one complication, then you have to hold anticoagulation. Now it increases the risk of thrombosis or et cetera. So it's a tough situation to guide through.
No matter how, it takes a very careful, hard-thinking physician to help guide you through those things.
Yep.
So we have a question, why are some cancers harder to treat than other cancers?
A lot of it.
That's a great question.
Take your time on that.
Quickly, though.
Don't
take your time.
It all has to do with the tumor biology. There are some cancers like pancreas cancer, bile duct cancer that are very aggressive. They develop a lot of mutations, and these cancers spread. There's not one or two different driving mutations. There's multiple. And so every patient's pancreas cancer is very unique from the next patient with pancreas cancer. You take some malignancies, let's say some blood malignancies that are relatively treatable, low grade with a couple doses process of chemotherapy. They only have a few driving mutations. You knock off those cells, and you can essentially get cured.
So it depends upon the biology.
Yeah.
I think the poster child for that is prostate cancer. It goes from very aggressive to we can watch it and do nothing.
Yeah, and they do sometimes,
Yeah.
many times,
Do
they
just
do,
as well.
They do. Most of us, if we live long enough, will get it.
Yeah.
Yeah.
Acid reflux for years. What suggested treatments?
I guess if it's for years and it hasn't responded, I want to know what's going on. Probably need a
Diagnostic
look
workup.
down in the tummy and an endoscopy, and then decide.
Yeah. Please give us your opinion on hospitalists following serious surgeries. The caller states you don't get to see your surgeon and hospitalists don't know you. What do you think about them at the Mayo Clinic? So hospitalists, the problem is they're rotating.
True.
You don't always know that person is following you. What about the Mayo Clinic?
I mean, I can't comment on other institutions' practices, at least for us in my division and most of the surgeons. We see our patients, we have close relationships, we keep them and we watch them, we manage them through their postoperative course. If we need assistance, particularly for some difficult internal medical issues, we consult experts like Dr. Lohr here to see our patients specifically.
Yeah, and that's what I do is see patients in the hospital after surgery most of the time. And you're correct. We rotate. I'm on a week at a time, and then someone else comes on, and we do have to make a handoff. But we have, I think, good ways to do that. I think the critical thing here is that there needs to be very close and continuous communication between me and the surgeon. And if I'm suggesting we do something, I talk it over with the surgeon. Yeah, we can do that, but we got to wait another day, or no, we can't do it at all. What's the alternative? You just have to communicate.
Communication. One more time.
That's right.
The value of communication. Necrotizing pancreatitis. What's that?
So that is a very severe condition. A patient develops severe inflammation of the pancreas. Usually most common causes are alcohol or gallstones, most commonly in the United States. There's various forms of pancreatitis. You can have simply some abdominal pain and a slight elevation of your enzymes, and that's about it. And then some patients can have really severe forms where they actually lose the blood supply to the pancreas, and it necroses, hence the name. Those patients, they become life-threateningly ill. Many of them have high mortality rate.
And of course, there is a risk for pancreatitis following Whipple procedure. And I knew that going into that.
There's a risk of leakage, a pancreas leak. So from the connection, if we do a connection, there could be a leakage from that.
Yeah, but generally not pancreatitis. You don't see
Generally
a lot of pancreatitis.
we rarely see pancreatitis after Whipple surgery.
Okay. Does a tendency for brain aneurysms, or in general, aneurysms run in families? Bob?
Yeah. Yes, they do. There is some familial aspect for aneurysmal disease.
There is a gentleman, non-smoker, 40s, died suddenly of an abdominal aneurysm.
Well, abdominal aneurysms we do screen for, and there's a subset of patients, mainly male, and people who have smoked and over a certain age. The current recommendations are to do a single abdominal ultrasound at age 65 and look at the diameter of the aorta.
Yeah.
If you're not in that high-risk category, you don't have to be screened. There is no screening for a cerebral aneurysm.
Right.
And
But
there is some familial aspect.
There's
of
some
those.
patients with connective tissue disorders, and
Yes.
they may have an isolated
Marfan.
peripheral
Yeah.
aneurysm. Then you have to screen for a cerebral
Right.
aneurysm in those patients.
And polycystic kidney disease is another group that
That
can
has
have those.
aneurysm.
Yeah.
I think, though, the big risk factor is smoking. I mean, it's just
Yeah.
huge. I mean, a heavy smoker comes in with abdominal pain.
Yep.
That's the first thing I think of.
Yeah.
Just wanted to express how great the Mayo is, and thank God for it being in the Midwest. Love the collaboration. Went there for my sarcoma. That's a nice thing to hear.
We'll take more of that anytime.
Quick comment about the fact that the Mayo is really a great institution and has the reputation that it deserves in my mind. And when I started practicing, the complicated cases we sent to the Mayo. Now we have experts in Sioux Falls that I send to for the most part, but not always. There's a time when you need the guy who really knows.
You were an example of that, because I recall the call to me was you were scheduled for surgery, and your surgeon said, I've looked at this scan one more time, and the blood vessels around the tumor, I think you need to go on. And You did.
I did. And I can't thank you enough for making this connection.
Well, it also says a lot about the surgeon that you saw. So,
It does.
we
It did,
kind of
didn't
talked earlier,
Yeah.
what makes a good surgeon isn't necessarily everything they do in the operating room and making a decision to go to surgery, but making a decision maybe surgery's not right at this point in time.
Or that
And then
I
avoiding-
need to send to
Yeah,
another
you bet. So that takes a lot. A lot of surgeons get a lot of bad reputation of having a lot of ego. That took someone to say, I think I'm
agree.
going to refer this patient elsewhere.
It was-
So that was a very thoughtful position.
Yes, it was. And I was there. I was going to be done there. And then at 11 o'clock the night before the procedure,
You got a call.
I got a call. Had a neuroendocrine tumor removed in 2014. Had it removed in Sioux Falls, lost 60 pounds after the Whipple. Is it normal to lose weight and have to watch my diet? My stool is different. Is that normal?
You can answer that.
And I think the answer, I've looked at it. The two people who have survived Whipple procedures at Pier that talked with me, both of them were in the mid 200-pound range when they had their surgery, and are now in the mid 100-pound range. They both lost 100 pounds, and I lost 170 down to 145, and I've regained, probably 7 or 8 pounds. And one thing that has helped me was the creon, the pancreatic enzyme that you prescribed for me when my pancreas is working well for endocrine function.
You're not diabetic.
I'm not diabetic,
Right.
but I don't make the enzymes to help dissolve the food,
Yeah.
and enzymes might be a help for you.
Yeah.
Hysterectomy from precancer cells, do I need a pap smear, Bob?
Yes. If there was some malignancy or precancerous, then we do continue vaginal pap smears after that,
Right.
or HPV testing. Yeah,
HPV testing meaning?
it's the
warts.
virus. Yeah.
Human
Human papillovirus.
And any comment?
Papillomavirus.
Papillomavirus,
Yeah.
Okay, and you agree?
Yeah.
Okay. A caller from Brookings has been diagnosed with a low-level prostate cancer, and I'm being observed without much change. What are treatment options and side effects to consider? So that's an important issue about prostate cancer. Either one of you want to jump in on that?
Recommendations have changed, but as you mentioned, there's a
Yeah,
wide spectrum of aggressiveness. So.
If the histology of the tumor under the microscope is pretty innocent, pretty non-aggressive, then observation, continuing to check for symptoms, following the PSA level, that sort of thing, is perfectly fine. And
To watch and wait.
So watch and wait. And if the tumor turns more aggressive, the PSA goes up, then you can re-image and you may need some other treatment. But watchful waiting is perfectly fine. Now that's one end of the spectrum. The other is the aggressive tumor that we know is going to cause problems, and that requires radiation and surgery promptly.
Very good. Thank you. And now for the winner of tonight's Prairie Doc quiz question. A primary care doctor refers to a subspecialist, often to help define the diagnosis so as to better treat a condition. A Mayo Clinic study found that the percentage of the time the final diagnosis was entirely different from that of the referral diagnosis was A, 12%, B, 21%, C, 99%. The answer is B. 21% of the final diagnoses were different than that for which the patient was referred. And it doesn't surprise me. It was Kathy Saramda of Watertown who answered the question correctly. Kathy, thank you for participating. A book will be in the mail to you soon. We'll be right back after this.
Because they want you to be there for the many milestones yet to come. Because you don't want to miss out on the little things. There are many reasons to get life-saving cancer screenings. 1 in 8 women will be diagnosed with breast cancer in her lifetime. But regular self-exams and mammograms can catch it early when it's most treatable.
Promise?
Promise. 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 Promise.
Make the promise to get screened. Do it for the people you love. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
William Worrell Mayo influenced the beginning of the Mayo Clinic. He had a curious and remarkable life. He was the descendant of famous English chemist John Mayo, who in 1668 first recognized and proved the existence of oxygen. W. Mayo was born in England in 1819, where he studied science and chemistry. Mayo left for New York City to work as a pharmacist, but soon moved west to attend medical school. First, he trained in Indiana, but finished his MD degree in Missouri. There in Missouri, he was troubled with recurrent bouts of malaria, which he blamed on the southern heat. This brought him to move north to Minnesota for a healthier climate. He lived in several Minnesota towns, including St. Paul, Duluth, Le Sueur, before finally moving to Rochester. During those times, W. supplemented his medical practice by tailoring, farming, operating a ferry service, serving as a justice of the peace, and publishing a newspaper. He was called to serve as a physician during the devastating Dakota Indian War of 1862, which ended near New Ulm, Minnesota, and concluded with the hanging of 38 Dakota Sioux Indians. In 1864, young Dr. Mayo moved to Rochester, bringing his wife Louise, 3 daughters, and young son William James, or Will. He came for a job with the draft board to perform examinations for the Army. After the Civil War, this 5'4" tall man, called the Little Doctor, set up medical practice in Rochester. His second son, Charles Horace, or Charlie, was born there. While W.W.'s practice became busy, he served as alderman, school board member, mayor of Rochester, and member of the Minnesota State Senate. In 1883, a destructive tornado came through Rochester, and Mayo turned for help to the Sisters of St. Francis, a teaching order with little medical experience. His eldest son, Will, had just returned to Rochester after medical training, and his second son, Charlie, still in medical school, both joined W.W. to care for tornado victims. In response to this experience, the sisters later built St. Mary's, a 12-bed hospital, with the 3 Mayo doctors as surgeons and the Sisters of St. Francis as nurses. The success of the Mayo Clinic is said to have happened because of W.W.'s early concept of a group practice and his appreciation for collaboration. It all started with the dad and 2 sons working together, along with the sister teachers turned nurses, and the research and education that follows the shared work of a team. Well, a big thank you to our guests, Dr. Bob Lohr and Dr. Mark Truty, who have volunteered to travel all the way from Rochester to Brookings, 4-hour drive through that crappy weather to help with tonight's program. About 4,000 young people nationwide are diagnosed with a rare disease with no known cure or treatment called Friedreich's ataxia. Most Friedreich's ataxia patients will require a wheelchair before high school graduation, suffer from teenage onset heart disease, and some die in their 20s. A promising new treatment may be on the horizon for Friedreich's ataxia, and it could save many lives, including that of a 16-year-old Sioux Falls girl. Her father started a crowdfunding campaign to fund this hopeful research. If you'd like to learn more, visit the website on the screen. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Go get your flu shot if you haven't. It's around, it's hitting us. And until next time, stay healthy out there, people.
RN, CNP, physical therapist, pharmacist, the list goes on and on. Opportunities for working in the health professions. Next time, On Call with the Prairie Doc.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions.
Brookings Health System, Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen District Medical Society,
Black Hills Medical Society,
3rd District Medical Society, Brookings, Madison, and Flandreau,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
and Swiftel Communications.